Would you like greater influence over the patients that come to see you? Would you like to know which factors in our day-to-day conversations are particularly persuasive and as a result will lead to greater adherence, buy-in, and belief that whatever we're going to suggest is going to help? If so, then this episode of Clinical Communication may just be for you. Today, I'm speaking with Andrew McCauley, who's a specialist physio both in the NHS and privately, and he's also an athletic development coach. In addition to that, Andrew also runs the Therapeutic Conversations Unravelled podcast and also runs the Unravelling S&C course for therapists. In this episode, we're discussing a topic we're both particularly passionate about, and that's on the work around influence and persuasion by Robert Cialdini. We'll be discussing which factors from Cialdini's work that you can use in clinical practice for any person that you see, regardless of whatever speciality you are in, to have greater influence and be more persuasive. If you find this useful, please do go share it with others. Please do subscribe, and please do send any questions or stories into clinicalcommunication@outlook.com, and I may well read them out. At the beginning of this recording, I give Andrew 10 quickfire questions like he does to his guests on Teacup before we get into the main conversation topic and meat of it. Thank you for watching or listening, and I will speak to you next time. There we go. Okay, right. Andrew, are you ready for your 10 questions to start?
Let's go.
These are one or the other. You can't have both. You can't pick an alternative. So, number one, coach or therapist?
Coach.
Mosley or Gifford?
Gifford.
Night in or night out?
Night out.
Night out. Okay.
Oh, yeah.
Football or rugby?
Football.
Ireland or Cornwall?
Ireland.
Deadlift or squat?
Deadlift.
AC/DC or Guns N' Roses?
Oh, I hate both of them. AC/DC.
Beach, beach holiday or skiing?
Beach holiday.
Teach or treating?
I said this to Joe Gibson a while back, and she had the same thing. And I remember going, yeah, this is a tough one. Oh, man. Oh, the other one's been quick. I'm going to say treating.
And finally, NHS, ESP or private?
Private.
Well done. You only had to, what was the one you had to think about?
Yeah, that is a good one though. That one, I do like that question because it is a lot. I know the ones who have asked before, and they'll go. I know the ones who'll say teaching. Teaching is really good fun as well, and it's a different aspect. But I tell you what, why I went with treating was because it's. Who was I saying this to the other day? I'm probably repeat myself, but the buzz you get, like when people, either recommend you or review you or say to you that it's changed your life, you know what I mean? Whatever about teaching and courses, and people are like, oh yeah, great, I'm going to change my, change the way I think about things in physio or therapy, whatever they're doing. But a patient who's like going, I can now do this thing, or I can complete this task, or I can go and do that marathon, or I can do that. You get a proper connection there that I think, I think that's what I chase.
I think, to be honest with you, anyway. We both teach and treat. I think the ideal is a mix. From experience.
Yeah, well, that's true. Yeah.
I think this is personally from experience. You build up your experience, treat loads of people, and then I think once you've done it long enough, the teacher just helps break it up, and just doesn't feel as monotonous. Helps, from my side, just help make the week more varied. Ben Cormack made the joke to me that the variety is the spice of life. I think that's right for kind of clinical, because it's just mixes things up, and it means you're not just feel like you're going through the mill 5 days a week.
It definitely, like I can even break, therapists get, moral distress, empathic distress, depending on what job you have, like you're in pain. Pain side of things, that you can get 4 or 5 of them in a row, and sometimes they can be okay, and sometimes it is real tough job, mentally draining. And as I said, in the NHS, it has that, there's breaks in there, there's different types of appointments, there's injections, there's meetings, there's stuff that breaks, as you said, breaks up the day. My private practice is full on, but it's in with patients who are in kind of more athletic population. So we do kind of quite fun stuff, fun rehab that way, but it's really intense as well. And
Mm.
then, as you say, but then a couple of days later, then I might be teaching. So yeah, you're right. It definitely helps to have that break and that slightly different one. So I think anyone who's interested in prolonging their career, I think it's definitely, I think it's enjoyable. Anyone who does it, I think really likes that mix.
Yeah, yeah, agree. I think at times when over the summer and I can't teach, I can feel it a bit if I'm having to do repeated 5 days a week, seeing people all the time. And thank you for doing this, Andrew. After some
No problem.
hiccups with being able to speak. And this episode is a bit different to others I've done in the past because previously asked people to communicate about various conditions or treatments or clinical things. But you and I both have a shared large interest in about persuasion and priming and influence, and especially the work of Robert Cialdini, who we've both read about. And that's what we're going to discuss today, rather than some generic condition or treatment plan. What led you to become so interested in his work and this field, so to speak?
You know what's interesting? On reflection, I was kind of going, why did I end up looking at his stuff on YouTube? There's a lecture
YouTube.
on YouTube,
Yeah, okay.
and I think it was you.
Oh,
I think it was you. I think you several years ago. If I'm right, I could go back through my Twitter. Maybe I'm wrong. Maybe it's something similar. But I remember somebody on Twitter put up a lecture from him when he was releasing his Persuasion book, and it was an hour on YouTube. And I listened to that, and I was like, "On, I just love some of the research, which I still use as examples. It's just great, powerful kind of ideas around priming and stuff like that." So yeah, I watched that lecture straight away. Got the book Influence. I'm not great with reading, so I listened to audiobooks. So straight on to that, and then I got Persuasion after that. So I'm sure if we look back, it could have been because it was someone on Twitter said check this out, and I was always being kind of like not afraid of the word. Like I think the word influence in sales is its own, can have certainly negative connotations.
yeah,
But I was always I'm a half full person. So I was like, no, we can learn from this. We can learn from marketing. We can learn from sales. It's not that we're selling things to people. We're actually selling what they want and
yeah,
hopefully what they said they wanted, not we're selling treatments that we think is going to help them. Yeah, do you know what I mean? And I think around that time when I was on Twitter a bit, I remember just putting stuff about that up and you'd get people going back for it. It made me come off Twitter a lot. I'd only use it every so often because it was just so daft that we have this powerful bunch of research and this guy really explains it in great stories as well. So it's a really easy
yeah,
book to listen to. So yeah, and like as we both probably agree, like I've always think that communications it could be higher. We might as well use the 80-20 rule and say that communication's 80% of what we do and
yeah,
and probably even more
yeah,
and 20% maybe physical.
yeah. I think it might. I don't know if it was me or not. I can't remember that far, but
Take the credit. Take
I
the
will
credit.
take the credit because I don't. To be honest with you, I don't think it. Especially 3 years ago, I don't think it would have been anyone else, especially in Physioland, but me probably. Um, I discovered it for more than 5 years ago now, when I was dealing with athletes at the time, and at the time injury prevention things were very hot, and I had all these great exercises and things that were by evidence shown that they were, could help reduce the risk. The downside was it was trying to get adolescent or early 20 martial art athletes to actually try and do it. And I realized just telling them wasn't going to cut it. And I'd read a few books, and then I had a patient one day come in who'd spotted I'd been reading something else and brought up the Influence book by Robert Cialdini, and thankfully it's come out in the 80s. So anyone
Yeah.
listening to this can go and buy it on Amazon for about 50p probably. Um,
Yeah.
or on audiobook as you did. Did he narrate it himself or did he have someone else do it?
It's a good point. I don't know. I could find out. I don't know. I don't think it is him. No, I don't think it is him.
And he's only done two books because that came out in the
Yeah.
80s, and then
Yeah.
Persuasion was
only recently,
Yeah, like
isn't it?
5 years
In the
ago,
last,
something like
yeah, something like that. Yeah. Because that's the
that.
lecture I saw. The lecture I saw on YouTube was about that book, Persuasion.
So that's at least a 25-year gap. But arguably, two books that have, and a person that has provided more, to coin the term, influence over psychology and various other things than many other books, psychology papers at the time. Many people consider influence the Bible for influence and persuasion.
Well, like I think just to give people a kind of an idea is that the guy went into the whatever the top five businesses that are in sales,
Yeah.
like car sales, and he actually worked in that industry to listen. Like it's a it's not just a guy who's gathered research. He's obviously a psychology researcher. I don't know what uni it is. Can't remember the university. I think it could be Ivy League. Certainly one of the big ones anyway. And he's been doing marketing and psychology in that for years. But to go into these businesses, work with these people and learn, and then apply the research and get the research. So it's really, it's really interesting, to be able to do that.
It is. And a lot of it, it's actually what he's discussing in the books is very simple. There's only 6 principles for the influence book, which we'll discuss. And then he adds a 7th, and the idea of priming, which is becoming more well known more recently. Before we go through the list, just so I know and so everyone has an idea, because they probably haven't heard of priming before. So, how would you define priming to those listening and how you've used it?
So the way, yeah, I keep it really simple. When it comes to priming is and maybe just an aspect of priming is that certainly in a clinical field is that what somebody experiences just before they see me, for example. So they might be in a waiting room, waiting for the appointment, and then I'm obviously going to be going through a therapeutic or developing hopefully a therapeutic trustworthy relationship when they come in. So the idea is that they're going to trust me. We're going to have a conversation. We're going to try and hopefully come to a collaborative approach towards a treatment that they're going to have to get better.
Yeah.
So I want to encourage trust and maybe some hard work. I want them to be able to these behaviors, positive behaviors around change, behavior change perhaps, or whatever it might be that we discuss. So the idea of priming is that is there something in the environment or something you may say before they come in to see me so that their behaviors are actually going to be primed for receiving the information or maybe being in a certain state. Is that does that
Yep.
kind of cut it for you? Does that
Yeah.
I can give you examples of the type of research that he mentions that is quite
Yeah,
clever
go for it.
around that. So another thing then I use then is so like I've just been mentioning, like I really like the idea that my approach straight away is I want to explore people my first goal is explore them as much as possible. And that can organically grow depending, but generally the first set, let them go, explore every aspect of their life as much as I can, and then build connection as fast as possible. So connection is going to be key. And that will be one of the other principles we talk about, the similarity principle, which I build on. And then I want to collaborate. So that's my 3 general rules: explore them, connect with them, and then we can collaborate towards an agreed goal.
Yeah.
So in front of my patients, for example, he talked about imaging, and I think if I've got the right one, is there was a study that was done, and it was really interesting. I show this on my course, and I don't tell them the age group of this particular cohort, where they come into a researcher who's sitting at a table, and he has or he or she has pictures of household items on cards, but in the cards are watermarked 3 different pictures. So one group was one person standing alone in the background. The second group had 2 people separated. If you're watching, it's like 2 people standing apart. Yeah. And then the final group had 2 people together, standing right close together. That's it. So these are the images that are on the back for each group. And they're just showed things that are household items. But interesting, what happens, the researcher at the end gets up and drops the cards, and they measure how many people from each group help the researcher pick up the cards.
Yes.
And the first group, with the one person standing there in the background, 20% of that group helped. The group which had the 2 people standing apart, there was only 20%. And then the last group that had the two people standing beside each other, 60% of those helped pick up the cards. And what's the nice little kicker at the end is I zoom in a slide of it's 18-month-old children that were the actual recipients of this communication, if you like.
Yeah.
So there's a whole bunch of other studies that looked at this, which is the idea that the image you see will evoke a certain behavior that's going to come next. So the idea of two people standing together, that is a connection, you're collaborative, if you like. So in my waiting room, in my private practice, I have a picture of Muhammad Ali and Pele hugging each other.
Okay.
So it's so it's like two people. So that's the first when you sit there waiting in the room, that's what you see.
Yeah.
Now don't hug my patients very often. It's very, very, very rare. But the idea is that you've got two icons, but you've got this connection. So people might sit there, and I think this is the kind of, some people might be dubious of stuff like this, but this has been repeated they've done it in call centers around people sticking hard enough. I think what they did was in the call center research, they looked at a person running over a marathon line, and then they had the list of things that they want those guys to do on the call. And then the other group just had a plain white piece of paper with the list of things to do. And again, what was interesting is those who had the picture of the marathon runner completing a marathon or running over the finish line, they stuck significantly longer to the task and did better sales. So again, it's this idea that pictures evoke behavior. Yeah. And I think that's pretty cool, and I think it's just looking at those small things we can do about behavior. That I don't know if we do that well enough in what we do in therapy anyway.
So I did a similar thing to our department. So pre-COVID, our physio department was, you can think generic NHS physio department, like had the anatomical pictures on the walls, some explain pain spiel in size 11 font, and anatomical pictures, etc. COVID happened. During the early stages of COVID, the hospital took it upon themselves to, while there were no patients around, to redecorate. And as part of that, myself and my colleague kind of thought, well, let's give this place a revamp. So we binned all the anatomical pictures, all the biomedical stuff, etc. And after some delays, if you were to walk down through our department now, you would see on the walls, instead of all that medical stuff, you would see pictures of people being active, be it walking, garden, swim, whatever, in nature. The premise of the nature, people find it calming, but the active is to prime them. They think about, hopefully, activity or hobbies, interests, that's thinking that way, rather than thinking biomedical, structural, etc., which makes, it just makes those conversations easier. Now, we haven't done a study to see if there's a difference because I didn't have it before, so I can't compare. I can tell you the conversations at times are a bit easier, but even from those results, I think the key thing we should also point out is that study with where there's what you mentioned there, it's not like it went from 20 to 100%. It was 20 to 60%. There will still be people it doesn't, for all these things we discuss, it doesn't impact, and that's okay. But it increases your chances, increases the odds.
This is what I'm an odds person. When it comes to these things, like as you said, there's people who are going to look at that and go, I don't know who that is, don't know what that means, and I get that, and they'll look at it. But it's interesting you say that, because behind them is pictures of jumping over a hurdle or running up a hill. Yeah. And I have one quote in the room, and the reason I mentioned the quote is I'm not a big quote person. I do like quotes and stuff, but I think they end up getting a bit like overused, if you like. But one quote is from a psychologist called Angela Duckworth. Okay. She's written a book called Grit. It's a really good reference if people are interested in. She's done a lot of studies on people who have grit are more successful. Effectively, it's that classic. You can have talent, but unless unless you really put through the hard yards and dig your heels in, you won't be successful across. She's measured across loads of different areas, sport and finance and military, all sorts of things. So it's really, really interesting. But she says enthusiasm is common, but endurance is rare. And it's just written above, and not everyone says anything about it, but the people, and this is the thing, what I'm really interested in, is that someone goes, I love that quote you had up on there. Like, and they'll talk about it for 5 minutes with me and where did you get it and all that. And if that one patient, because we're dealing with that patient comes in and they, especially in private practice, I'm looking for like super spreaders. So I don't see people an awful lot. I don't do manual therapy. I don't do electrotherapy. Mine's completely on coaching and exercise. That's what I do. And then, and or signposting to appropriate areas of medical help. So I'm all about like people going away and saying that was a great appointment and telling their friends and being a super spreader, if you like. That's the kind of model really that I'm trying to do. So the people who kind of see these little details, it's just like anything else. They come into clinic and they go, oh, you've got that. Oh, you wear that watch. Oh, you've got those weights, or you've got that type of weight. So I have a certain brand that's more towards CrossFit and weightlifters who kind of go. So now I get 70-year-old tennis players or 70-year-old people who've had a hip replacement. They don't care what brand the weights are. But those who do, it matters. And then they go tell their friends and then they think, oh, well, they're the same people as me. And then you have that, you develop this community. It doesn't happen overnight, but these subtle little changes, like the pictures, as you say, not everyone gets it, but I'm going to roll the dice there,
And something you mentioned earlier, which I just want to jump into before we get into the other factors. And I haven't had it as much, it sounds like, compared to you, but still the word persuade, the word influence, even, dare I say, manipulate, not from the physical, but psychological, I think makes some people feel uncomfortable.
Yeah.
And I'm on the same board as you. It's fundamentally, we are trying to persuade or influence or manipulate everyone we see. Even if you don't think you are, because you want them to do these, from a physio side, exercises. If you're a doctor, maybe it's the medication. If it's a dietitian, a diet, whatever it is, okay? Even just trying to build a good rapport and relationship is persuading and influencing, you know? It really comes down to, you're going to be doing it no matter what. It's, if I'm doing air quotes here, bad or unethical on what your intentions are and what you're trying to achieve from it.
Yeah.
Is the government back in COVID being unethical for the persuasion and influence and stuff by telling people to, limit the virus contagion and whatnot? Well, probably it's a good thing that they said that. But if someone doing it from a flip side for financial reasons, then maybe that is unethical. Okay. But I agree with you that these aren't bad words. We're doing it anyway. You can't not persuade someone. You can't not manipulate someone. You were talking about priming, just having a physio or any uniform or just your name or how you look will influence them.
Yeah. So the one thing I would say, I actually, when I was thinking about influence as well, I'm going to come back to it as well, because I looked up the definition kind of thing, which I'll come back to in a second. But when someone comes in, like I said before, I'm exploring them in the early mod. So I'm a big, as I said, I'm a coach before a therapist now. I would have definitely maybe been something different 10 years ago, but because I think that's what we are, because somebody comes in and we assume that they want us to help them with our techniques or whatever. But actually they may just need some advice about not doing something that they were scared of. And then they want to leave. They don't want any of your bits and pieces or your anything. They're just like, okay, I now know it's not that. So you're cool. I'm all right. Do we actually give people that permission to say that? I think as therapists, we want to help them. So that means we don't really see that someone's actually going. I had a guy today and you could clearly see, he's just like, I'm grand. He said, he came in, he went, I just don't think I need to see anymore. You've done a great job. And he still had bits and pieces. He was an 82-year-old with shoulder away, but he just was like, I'm gone. I don't need to be here. And I was like going, 10 years ago, I probably would have went, all right, but I need to do something else with you here. We both just like big handshake. He was laughing, I was laughing. And it's just like, no, you've made the decision. And it's no point in me saying, oh, but what happens if you do this and all that stuff? No, that's not important. So as soon as I go in, I'm exploring people, I build that connection. And then we both sit down and I have a whiteboard and I say, well, where are we trying to get to here? Like, what are we doing? Like, getting out of pain, of course, but what's the real desire here? What's the want? What are you missing in your life that this pain or this thing is missing? Because once we've established that, then yes, I am going to influence, manipulate, sell that, because they've just said that's what they want.
Yeah.
So the person sitting in front of you will be very logical, and they'll, not very logical, but they'll be like going, okay, they'll be listening in that sense, in that scene, in that incident in clinic. They'll be like, yeah, oh, okay, I'm paying for this. I'm listening to him. The guy seems like he knows what he's talking about. What happens when they leave the clinic on a Tuesday night when it's lashing rain and they really don't want to do your boring exercises that you set them? What
Yeah.
happens to their brain then? Because that's where all these bumps, or this is where commitment goes. And I need them to go, oh yes, we want this. We want the goal. We set that out. What does it look like? Oh yeah, sorry, yeah, I'm going to do that. That's what we said we're going to do. So I have to make sure that I've sold them, I sell that, I influence them over that,
Yeah.
because that's what we agreed was the goal.
Yeah.
Do you know what I mean?
Yeah. 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 So first, I've got in our list of Cialdini's, there's 6 of them, of his factors for influence. I'm not doing them in order of the book. I've got them in a different order here. The first one is authority. And in the book, and it's established many things, that the more expertise someone is perceived to have, the more we are likely to listen to them and go along with what they say. However, in this day and age, as we record this in 2025, do you think in healthcare that is as effective as it used to be, and if we can rely on it still?
Yeah, that's a good. You said that through to me, and I was kind of like going over. And what's really interesting is the way things like this happen. Is we had a journal club at work, the NHS work I do on Tuesday, and there was a paper which I brought with me because I just thought it's exactly that. It's authority, and I suppose what it was. The paper's by Peter Malarius down in Australia.
Yeah.
2021 paper, and it's physio's not going to repair a torn tendon. That's the opening line. Patient decision making related to surgery for rotator cuff related shoulder pain. Okay, so what they did was I'll just summarize very quickly. I think it was 10 people they interviewed who've had rotator cuff surgery, and they wanted to look at how did they come to this decision and what the patients said and stuff like that. And then what some of the quotes that they said that the therapist or the doctor or the surgeon had said as well. And what's clear is that even in that small sample size of study, there is that still authority, especially in these kind of mechanical problems. Now, it mightn't be the same in other areas, but certainly in this, and rotator cuff is a real kind of gray area with regards to shoulder repair, and quite a lot of research showing that it doesn't do very well. Yet, these patients were really kind of like, oh, when the surgeon told me, and they also, which was heavily linked to imaging, so that the imaging and then the surgeon being, oh yeah, well, it's this and it was never going to heal, and why would that, and nearly kind of feeding that mechanical beat that was still quite popular in that particular study, that authority that the surgeon is up there. So I guess it's still there. And the other thing I'd add to that, it's probably changing, so I'd love to hear your opinion on it. But the other thing was when I work as an ESP or extended scope practitioner, so I see shoulder, hip, and knee referrals from GPs or physios who the patient's not getting better, for whether it's an orthopedic opinion, further imaging, etc. And one thing I notice is I don't wear a physio uniform.
Yeah.
And I have a black polo shirt. You're probably the same. I don't have that white polo shirt or horrible blue pants kind of scenario. We look like, no offense to pool cleaners, but we do look like a pool cleaner when we're trying to deliver quite important information. So, so once I swapped from that about 10 years ago and had my own room and my own computer with the imaging on it if I needed it, the difference in how patients would certainly take certain information I was giving them, especially around like discussing surgical, and a lot of the time I'm talking about not having surgery. Let's put it that way. The amount of times, it's very rarely that I'm saying like we're going to go there. In fact, I have to have that authority to say, look, surgery is not required, and you need to listen to me about the imaging isn't going to change what we're going to do. So I think it's still there. I don't know. What do you think?
I think a bit, yeah, especially when I still have it a bit where occasionally I wear a traditional physio uniform, and other times I wear, just like you say, kind of smartish non-uniform. And I feel patients take me more seriously when I'm wearing the smartish uniform compared to generic physio uniform. And also, my boss and I have this phrase where sometimes, and this can sound a bit sexist for me to say, but sometimes the patient just has to be told by a man in a suit, basically, for a
Yeah.
certain time. They just won't hear it or just won't accept it from anyone else. It has to be consultant, doctor, whoever, has to answer said question for them to feel they're able to move on. I would say, obviously, everything is individual. I think certainly the 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 days of the patients coming in and saying, "I will do this because the doctor, physio, whoever said so," is gone. Like there's a small generation left that still applies to, but a lot of the generation now, especially with all the internet access and AI and all that jazz now, and from certain people's experiences in the past, I think there's a lot less trust is the word, or just willing to just
Yeah.
go along with it.
I know what you mean. Yeah.
So, but I think how, and again, the priming of how you're presenting yourself, you say this person walks into a private room, um, and you're probably introducing yourself a bit differently compared to physio. All those things combined give you an air of a bit more authority compared to maybe in the past or other people they've seen so far. I hear it from plenty of other ESPs like yourself, where the patient was doing all the right rehab, the physio suggested all the right things, but they just wanted the imaging, they just weren't accepting it. And until they sat down with the ESP or more specialist person, then they were willing to change their mind or hear it more. But I
And
certainly,
I
yeah.
think I think that's what's interesting. This is so difficult to research. So when you're trying to explain this to maybe therapists who are new to it, or because we definitely know, and you know this obviously very well, is that we don't value communication
Mm,
training.
mm,
As I said on my podcast and yours, similar thing. Everyone, there's something about, like, I spoke to Ben Cormack about it, and he's like, it's not tangible, is it? It's hard, it's difficult to measure whether you're good at it or not.
yeah,
And no one wants to be crap at it. You're
yeah,
not in the business of therapy to say that you're not really good at it. We all think we're all right at it. And I'm not saying that I'm brilliant at it, but what I have done is noticed how it can be done really badly when you
yeah,
haven't had the train, or when I've had training or I've read around it and gone, wow, there's so many things that I've done poorly in the past. And I think, I wonder, we've a problem because it depends on, this patient may have had access to different people along their journey. And I think that's the other thing, that, like, who they've seen, they build up a kind of a little shit repertoire of poor clinician conversations.
yeah,
And that might be because they've had little time with a GP or whatever. The GP just doesn't have an interest in that area. It's very difficult. It was just the wrong time, but that just sets up the journey. And then they get so frustrated by the end that,
yeah,
yeah, they just go, just image it. I have no more time for your games. And if your communication at that, if you're the person delivering it there, and it needs to be bang on, or you really need to know what you're at that point, because patients just are going, I need this, and nothing else is going to change.
yeah,
So
yeah,
I think it's a point to make, that I think authority can be there even if you're a junior therapist. You
yeah.
can still show authority in the fact that you've got, like, you're transparent.
Mm,
You're like, look, I've got support here. So, like, I've got really good support here if I need it. I can discuss if I don't feel like we're getting anywhere within a certain amount of appointments. At the moment, everything you've told me looks well within what I would expect.
mm,
I'm not concerned by that. So just improving those little bits of conversation to
yeah,
say, like, look, and if it doesn't work out in the next few months, then I've got a colleague here who will be happy to help me, and I get to speak to them every week. You just have to tell there's nothing wrong with telling patients that kind of can be really reassuring for them.
absolutely, absolutely. So the next principle we're going to go on to is, you mentioned scarcity. Now,
Yeah.
this especially applies to sales, um, where people have seen this online. Buy this now, there's only 3 left, or do this within this certain time frame, otherwise it's gone. The premise being, if something is rare or there's not much of it, we will get it quicker compared to if there's a lot of it, because it gives the impression that a lot of other people think it's good and have bought it. It's never something I've thought possible or tried to use. Have you found any ways to use it, that principle, with patients?
Yeah. Well, the closest I could get to what this was, which because when I set up my private practice, which that was probably prior to it was about 5 years prior to the Cialdini stuff, but I was looking at I set up the business and I lucky down here there's like unlocking potential, which is like you can do a 2 day course. You see they bring in loads of it was actually brilliant. They even gave you I even got 5 grand off them to set up the website and stuff, and
Mhm.
they put you through marketing and accountancy and just establishing branding, and it was really top level stuff. Like some of the people that came and did it, the mentors were like some of them had worked with Red Bull and really kind of high level stuff, and really really nice people. And I remember them saying to me one time they asked people to go up and draw their customer, and I was just physio NHS for 10 years. I was like so I went up and I tried to draw this picture on this whiteboard. It was the most embarrassing thing of all time, really. I'm not a drawer. And then I was like trying to draw, and and he just went, "Yeah, draw your ideal customer." And I was like, "I draw this terrible stick man, like it looked like they had flares on." And then he just went, "It's okay." And he just went, "You have no idea who your ideal customer is." And I went, "No." I said, "I kind of do." But then I was like going, "I want to see everybody." That was in my head kind of thing. But so he just went, "It's okay." He says, "That's why you're here." And we'll sit down. And I remember kind of going, right. And we established that later. And he said, "You're going to find out that your customers drive the same cars, wear the same clothes,
Mm.
say the same things, do all this kind of stuff, right?" So that's what got me thinking. Read psychology books, read a lot of Seth Godin. He does a lot of marketing, and he talks a lot about trust, building trust and branding and stuff like that. So that's kind of where I went to Seth Godin. Then I spent about 4 months on his. You sign up to it, and there's about 500 people on there, and he does lectures every week, and then you had to go away and go into your groups and discuss stuff and talk about all of the things that he brings up. Um, and the thing then he was saying about where you position yourself in the market. And I was like with you, especially in your line of work, because I think giving people more time is important. Like,
Yeah.
20 minutes, half an hour, it's just not enough time.
Mm.
You just don't get any of that connection. You don't get any of that rapport. For a therapist, you're trying to rush through the questions. You're trying to get to the bit where you have to assess, and then you have to get to the bit where you're going to give them something or do
Yeah.
something to them. And it's always been a rush. And patients feel that. And I always believe that. I said, nah, I think if we spend longer at the beginning, I think it's going to pay off. That was my theory in my head.
Yeah.
So I just went, right, I'm going to position myself in the market as 90-minute appointments. So
Mm.
new patient, 90 minutes. And often that would, I only see patients sometimes once with that. So the idea of bringing it back to that principle of scarcity was that because I see people for longer, there's less appointments. So once I built my rep, now people come to see it. I have a 4 week waiting list, generally.
Yeah.
So it's the idea of that they can't come in to see me, and then the by the time I'm 10 years doing this now, so because there's reviews out there, because there's good feeling about what I do here, then that's the idea that they can't come and see me. Then my clinic is never not empty. Do you know what I mean? There's that idea of just there's a scarce appointments. Right, I'll take that one. There's never an issue with that kind of thing. So I suppose I use that, and the fact that I think the only other thing I would add to that is I made sure that I had the kit that no one else, hopefully, in Cornwall has. So when you come
Ah.
here, you'll see stuff like if to the right of me here is a full rack of dumbbells from 2 to 50 kilos.
Yeah.
I've got about 700 kilos of plates. I've got every bar you could imagine. I've got a prowler in here. I've got a machine. If you walk in here and you're into strength training or into training, this is a gym. Like this is a full gym. I've got dynamometry equipment that will measure force and peak force and rate of force and stuff. So I've very much objective measurements, giving people data and feedback as a way of kind of going, will you get that anywhere else? Now I teach people to try and get that kind of stuff in their clinics. So
Yeah.
it's getting more popular, but still trying to have that scarcity that if you don't see me, you won't get that same quality.
Yeah. Yeah. Kind of be unique in a way. Is that right?
Yeah. Yeah. I don't know if is that
Yeah, it
scary?
does
I don't
make
know.
sense, especially from a business side of things. And I think it sounds like from all the reviews now and your 4 week waiting list, it's proven to be effective.
Well, this is it. It can always go away though. That's the worry. But yeah, yeah. Hopefully, yeah. Hopefully it's still there. Yeah.
Okay. So the next principle I've got here is reciprocation. So what that essentially means is you do something for me, I'll do something for you. Um, so classic charity one is we'll send you this cuddly stuffed toy. You give us £10 a month. And Cialdini highlights this many times that they do not have to match. So one, it's not like your things you're reciprocating have to be equal, as
Yeah.
you heard with the charity thing there. So I asked you, is it ethical to try and do reciprocation with our patients, and is it more
Yeah,
possible as
yeah.
well?
The good one was when I was listening back because I hadn't heard, and remember that Harry Krishna one they did. Harry Krishna's massively increased their memberships in the 70s. So Harry
Right.
Krishna religion
Mm.
was massive in it, and what they did was they gave a flower. They give you a
Yes.
little flower,
Yes.
and that was and their membership went. But then what happened is they would hang out in certain areas. They were masters at it, and they would hang out in certain areas of airports and stuff. And then they would come over the mic and say the Hare Krishnas are operating in this part of the airport, and stuff like that. But their whole thing was to give this flower, which was just blew my mind, this kind of random thing. But so instead of giving things to people, the ethical reciprocity rule really for me is kind of like what makes my business hopefully grow is word of mouth,
Yeah.
reputation, reviews. So if people are going to look me up on Google, they can look up a review. So if I'm going to do a really good job, what the ethical thing is if they say to me, "Oh, wow, you've really helped me," and I'll always say, "Do you mind leaving a Google review?"
Yeah.
If you've had such a good experience, that would be good. So they have done so. I have done something for them,
Yeah.
and I am asking them to do something for me. But that is hopefully ethical in the idea that other people are trying to seek a healthcare goal that I will try and help them with. I'm
Yeah.
not trying to, drag them in off the street for physio. Do you know what I mean?
Yeah.
And the other ethical thing, I suppose, if you use it in that way, I think it's a bit like any of this influence. There's a good and a bad side to it. The idea that in Cornwall, it's obviously a holiday destination. So I've had lots of people who call up and they're like down on holidays. So they're just on holidays and they might say, "Oh, have you got a slot, today?" And I'll be like, "No, I don't." But I'll say, "But what's going on there?" "Oh, we're down on holidays and my neck is sore and this is what's happened." I said, "Well, tell me a little bit about what's going on. I'll see what I can do to maybe help you, whether it's something important, or do you need to go to hospital? Is there any red flag stuff, or
Yeah.
is there anyone else I can recommend?" So I've spent maybe sometimes 20 minutes on the phone to somebody. Now, business people are probably freaking out that you're wasting your time. You should be doing something else. But I'm always thinking at the start, I would just do it. I don't know. It's just something I think, imagine being on holidays and you're in pain. It'd be
Yeah.
just nice if someone just told you what to do. So I would do this. But what would happen is I started to notice that obviously people are down on holidays, but they're down visiting their family. So then I would get this phone call from people and they'd be like, "Oh, I'm trying to book an appointment." And I'm like, "Oh, well, how did you hear about me?" And they go, "Well, actually, my cousin was down from London.
Yeah.
And you really helped him out and you said you were really nice. So we rang you up." So this idea
Yeah.
that sometimes it's just that classic, isn't it? Be nice, be sound, be kind to people. And that reciprocity will probably come back in
Yeah.
spades,
Yeah.
you know?
They will. They will. Especially with someone in front of you, if you're hopefully being nice to them and interested and sound, they will hopefully be nice and interested and sound back to you. They will start to copy you because that's how you are. Um, I sometimes, I haven't heard this for a while now, but I have had people say, "Oh, well, if we do our manual therapy, acupuncture, passive thing, whatever you want to call it, then they're more likely to then do their exercise as a result." I've never seen that in a paper anywhere. I don't know if you have at all.
No.
And I've certainly, now I'm like you, I don't do any manual therapy either, or really any passive things doesn't suit our clientele. But I don't know if that A works by doing something passive, whether it could be those, could be an injection, who knows. And then they're more likely to do the thing you actually want them to do. I've never seen
Yeah, and I
anything at
don't,
all.
it just that just doesn't sit with me, right? It's a bit like I have no problems with manual therapy at all. I trained in it. I trained in MACP level and all that kind of crack, and it just didn't suit me as a therapist. I didn't want to do that. Like some people get on ground with it,
Yeah.
but when you say that, if your thing is, I do this, people come to me for it, they get a good result, they like it, they enjoy it, etc. No problem, absolutely no problem for me. If they're saying that, like, yeah, I have heard that before. The other one they say as well is if I do manual therapy, we can build trust and communication through that. And again, I'm like going, yeah, okay, fair enough, but maybe just have a conversation face
Yeah.
to face
Yeah.
instead
Yeah.
of having to rope somebody to do that. But again, I get that sometimes people need to feel a bit more relaxed. It's a bit like a hairdresser, you know,
Yeah.
they start spilling the beans once they get something else kind of going on. But yeah, so whatever about the communication bit, I think the idea that you would, I'm going to do this to you so that you then do exercise for me. I would, even if that was true, I'd find that a little bit odd. I don't
Yeah.
know.
And
It
they're
just doesn't
becoming
sit right with
reliant
me.
on you. They're going to view what you did as the thing that helped them, not what you actually asked them to do.
I really don't think that's, I think that's the therapist potentially needs to maybe ask themselves that question again,
Yeah.
if that's the way they're doing it.
Yeah. Yeah. Yeah.
Do you know?
So, next principle is social proof. And this is the
Oh,
premise
yeah.
that we do things because we see the majority of other people doing it. Um, and you can apply this to various things in life. The premise of follow the crowd, essentially. And I've seen this plenty of times, not just in healthcare, but across life. And I'm sure we've all done it. How have you tried to use social proof with the people that come in to see you?
Yeah. So have you ever read Daniel Priestley's stuff? The Key Person of Influence.
I
He's written.
haven't, no.
Oh, he's written one book called Key Person of Influence. He's written a bunch of stuff. I got a friend of mine put me onto him. It's quite interesting as well, and you can see how it's done. It's that kind of idea of like you don't need to be this. There's so many smart people in the world, but they don't get their messages out. They just don't know how to become known. Or the word influencers. Now that's
Yeah.
why I was going to say that earlier on is a word that makes me slightly gag a little bit. You know what I mean? And content creators is another
Yeah.
one that slightly irritates me. But the way I don't want to sound like I'm about 190 here, but that those kind of things are definitely overused. But these people are obviously clever with regards to this idea of social proof as well. And what he says, Priestley, as well, is like it's getting that idea of like writing articles. Like this stuff is all quite ethical. It's like get good at what you do, but do it in this kind of order, and then people will kind of pay attention to you, and you'll get it. And social media is huge. You can see the big accounts in physio. Um, the guys who do it, and they're good mates of mine, and they put some really good stuff out, but it does definitely, you get booked up if you've got a high social media following. Like
Mm.
you will get across the world. Like I know some of my mates who do it and are well known that way go across the world. There's no way I'm getting booked in America or Australia
Yeah.
with 2,000 followers. This is not happening. So that idea of social proof is definitely big in our world. The way I've maybe done it, I social media is slightly, I struggle with it. I struggle with it a lot to kind of get out there. That's why I started a podcast for that reason, because I find it difficult to just continuously talk to people and find it slightly narcissistic. But anyway, but my thing was to sponsor local talent in Cornwall. So if there was athletes or that mainly athletes, so what they would do is they'd come to me and they'd come to buy the service. But then I'd be like going, you're top of your game. You're some of the, you're world champion, or at your age group, or so I saw a lot of youth. So I would look, I'm happy to see if for free, and if it's okay to put you on the website and just say that that you've come to see me. So it was an idea of this, and that worked quite well actually, because I did it for people who weren't famous either. I sponsored people who weren't like necessarily big time either, but they were just doing something really interesting, and I just said, right, I'll give you your treatment free. So that idea that people would see that was probably how I used it the most, I guess. It's a bit of a long-winded answer, but that's how I
Mm.
use it.
I think this is really where group stuff really, the social proof can have a massive impact, because whether it's a rehab class, an educational thing, someone's come in, and we see it on our programs all the time. They're more likely to listen to each other and the person going through what they're going through than they are to listen to us. And if they have someone who's going through what they're going through say, I've done this and it
Yeah.
helped, they're more likely to think it's a good idea, and they're more likely to do it, and more likely to get better as a result, compared to me just saying it and doing all the right things, but sometimes having it from someone else who's going through what they're going through, who can relate more, more empathy, etc.
Yeah.
Really, I think just seeing, and it doesn't always have to be just one, it could be multiple people. It might take a few people in that group to kind of buy into it, for the one person who's a bit reluctant to move forwards a bit more because they see the others doing it. I should say it's not a guarantee. There are some people in the world, and you know, I've seen them and I know a few, who are the almost anti-crowd, if I call it that. They will deliberately try
Yeah.
not to go along with the crowd, and that's part of their identity, and that's fine. But for a lot of people, and I think this is really where group can make an impact. If they see others like them doing it, it's much more powerful than just us saying it.
Yeah. No, yeah, no, great example. Yeah, I agree.
After social proof, the one I think most people find the easiest is the liking. The principle is essentially the more you like someone, the more you're going to go along with what they're saying. I'd
Yeah.
like to think that, especially as physios and hopefully more in healthcare in general, we're getting better at having patients like us. But my question I wrote down here for you is that enough? If they like us and we can be sound and use your own words, is that enough to help them buy into what we're selling?
Uh, yeah. When I read it first, when I read saw the question, I thought, oh, that's a good question. Yeah, because you know, instantly thinking, because I'm a big believer in like that similarity principle as well. That we might get onto that as well as that idea, like you're similar to me. Or,
Mm,
if you like somebody, you're more likely to. What I do get though, because I do a lot of second opinion, either ESP or in private practice, so people have seen lots of people before, and
mm.
one of the most common things that people often say is that, oh, they were lovely. The therapist was lovely. You know what I mean?
Yeah.
They don't come in and go, oh my god, that therapist was a real pain in the ass, and I didn't like them at all. Like you get the odd time you'd say you'd say that, but they're like going, oh, they were really lovely, and I really liked them, but
Yeah.
then something.
Yeah.
So that happens a lot. That happens a
Mm.
lot. So people are, and especially in this country, are genuinely the first thing is to be polite. That's where we have some problems around even how we handle patients. You know what I mean? I'm so much more aware than when I was started off because we were just kind of like you just pick limbs up and throw them
Yeah.
around the place and
Yeah.
touch people and be all right with that. Get them to take their top off and it's all grand, isn't it? And now it's kind of like I'm so glad I'm so aware because you can see it in some people who, when I asked them, I said, I'm just going to touch you on here just to do this test, and this is why I'm doing it.
Mm.
And you can see they're like, oh, okay, fine. Whereas in the past, that would have been like bosh straight in there, you know? So I think the idea of, I think people liking you is important, but sometimes I don't. Sometimes it's not important at all. Sometimes I have patients, and you can clearly see that we're not getting on. There's no, but there's a respect in the fact that this is the situation, and you have
Yeah.
to deliver. Sometimes, unfortunately, your options are these, and there's no other options, and it can happen an awful lot around, say, like weight loss, for example, which is a really difficult emotional conversation to have. I have to see that a lot with people with high BMIs looking for knee replacements and you're having to have this conversation so that I'm quite empathic with, I hopefully have a good communication style around it, but it still comes down to the fact that they have to do something really, really difficult and they're probably not going to
Mm.
like me for saying that to them,
Mm.
but they have no other option. So I think,
Yeah.
I think it's I think it's important, but I don't think it's essential.
Agree. Agree. Yes, it definitely has. I think it is. Will have a big impact, but we can't. And for those other reasons we said earlier, whether it's the authority, whether it's other things, just their experience, whether it's other factors, their beliefs, they could really like you. They could think, as you said, they think you're really nice and kind. But if they don't think you can help or what you're suggesting is going to help, then no matter how nice you are, it's not going to be enough. So I think it's still something we definitely, and I'd hope that as from what we're doing and other people are doing, this is becoming more aware, and hopefully people's ability to build rapport and trust is getting better. Um, but as we've highlighted, hopefully by now, it's not enough for everyone. Um,
Yeah, I just on that point, just to finish as well. Sorry, Ben.
sorry.
But like if you flipped it, like they don't need to like you, but I think what is really important is they need to trust you.
Yeah.
You know, when
Yeah.
it comes to because if we're influencing them to get to somewhere, it's usually hard, and and if it wasn't, they would have done that already. So they've got that goal, they're trying to get there, we're trying to help influence them. That is going to be hard. So trust comes down to it, and you don't have to like somebody to trust them.
No.
You know what I mean? I think you can have a respect there, and I think that's the difference with regards to influence, I think.
Yeah. Now, the one he added for persuasion, so he talked about the previous six in influence, and he added unity in
Mm.
persuasion, which is number 7. And you can please correct me if I'm wrong on this. Is the feeling that kind of everyone's on the same page? We're kind of working with, almost like a team feeling, a we, so to speak. Um, how have you tried to use that in real life with people in front of you?
Yeah, I was thinking that as well. I kind of because I couldn't remember when you sent that to me through, and I was like, oh, yeah. Now you say it like that, like I had written down a few things, and I'm probably repeating myself there here
Mm.
with you, like you as like again. I'll come back to it, and hopefully, I like things quite simple and not too specific, but like just a bit of a rule around it. So, like I said to you, first thing is explore people, connect with them, and then we can
Mm.
lead to a collaboration. That's always in my mind. So the unity I think comes from I think that's what I like again, maybe this isn't answering the question, but so I said to you before I have a whiteboard,
Yeah.
and I also have the fact that we sit like side by side nearly usually the way I've set up the clinic. So I'll go, do you mind me putting some notes up on this whiteboard so that we can kind of slightly distance them from the problem or the issues. They're not having it in their head jumbled up. There's a decent paper on that around the Solomon's paradox, which is the idea that we're not very nice to ourselves. But if
Mhm.
it's somebody else, we're generally a bit nicer. And there's a really good paper. I can't think it off the top of my head, but there's one talking about those who self-distanced from their problems were far more. They dealt with the information far better. They took it on board, and they were more likely for change. So the idea is that this unity is that me and like if it's me and you, it's like here's your thing. We're working together to get there. We're collaborating to
Yeah.
get there as one unit. We're not. I'm not here dictating. It's we're both looking over here to try and get that. So that's my body language is that way. I'm side on. We're working together. It is one union to get you to here. Like, and it always comes down to some. Like I see a lot of people who are like, I've got 3 weeks to go and I've got to do this thing, and then we have to stand. We go, okay, so like, what state is the biology? What's the task? What's the risk to your health?
Yeah.
What risk are you willing to take, and all that? So we have to go through that. So I'm like going, I want to get you there, but we need to be transparent with that. So let's work it out together. So that's how I do it.
Yeah. It's almost the type feeling of a team, right? That we're on the same page, they're part of
Yeah.
it. I think some people say tribe. I think this is where there's a lot of overlap with some of the other ones in this. So, like the you mentioned about the shared interests or things you can relate to helps with that. The we phrase. I like how you said about that. Actually, they're facing the same direction with the body language. Can I ask about the whiteboard out of interest? How big is this whiteboard? Because I've heard you talk about it before. I've never done it, but it sounds like a good idea.
Yeah, I've got two. Got one in my in the kind of where I've kind of slightly two rooms, a gym area, and then so I've got them in both rooms because I do all my notes on there as well as another form of so I do my shorthand notes on there, and as I'm going along, because at the end I video all my exercise, but all my educations or what I think is wrong, my impression of what I think might be going on and what we're going to do and why. So
Yeah.
that when the patient goes home, they've got a copy of that video. Plus, also I can just screenshot the pictures and they go straight onto my notes, so it saves time. So I'm able to get through more patients because I don't have to be writing notes or dictating notes. So it kind of works as two things. But
Mm.
the whiteboard itself is I'm looking at it here. It's about a meter by a half a meter, fairly deep. I'd rather a bigger one. I just managed to get that size. But I probably have a bigger one if I love them. I
Yeah.
love writing on them because it helps me think as well,
Yeah.
and it also is another body language. If you listen to this wasn't on purpose. But then looking back, when I read stuff around body language, it's that idea that you're thinking, you really are analyzing it. So I asterisk all the issues at the end in a different color so that they can look at it as well. So they're kind of going, all right. And I said, so here's your story. This is what happened. We talk it through. This
Yeah.
is what this, here's the things that were, and then they go, right, yeah, okay. And then I'm like going, and here are the things that are coming up physically. And sometimes that physical thing is clear. And
Yeah.
then we've actually gone back to the subject and we're like, well, your sleep's crap. You've had about 15 colds this year and your stress is super high, And then they go, right, okay. So you don't even have to say anything. So it
Yeah.
just helps with that whole communication, whether people are visual or whether audio or whether seeing it or a mixture of all. That's how I do it. So I can't go back from that. And I do it in the NHS as well. I don't have a whiteboard in the NHS. So I just use a sheet of paper sometimes. So it's not as effective, I don't think. But yeah, I still video everybody on their phones though
It's
for that
shared,
reason.
it's shared thinking. You're kind of showing them
Yeah,
your process, which helps them understand your thinking as well. And they can ultimately, if they're really engaged, they're going to chip in. They'll correct you if you've gone wrong or want to add something perhaps. Or
absolutely. Yeah, that's a really good point. Yeah, because sometimes you kind of go and it's like, have I got that right? Because I'm writing it, then I'm like going, so that did that change? Sometimes we do symptom modification stuff, like
mm,
change the symptoms, and I'm like, and sometimes patients try to please you a little bit. Yeah, oh yeah, it's a little bit better. Yeah, I think it's a bit better. And you're like going, that don't sound like it's better to me. And then they're like, no, it wasn't that much better. And I'm like, okay, cool, because we don't need to worry. You don't need to. And then it's that communication that leads to them going, you don't need to please me or anything. This is about getting it right. Because like some people are not worried about that, but a lot of people are. They're there to kind of they're nice people and they don't want to let you down either. Some people come back and they're like, oh, I'm really sorry I didn't do this, and I'm really sorry I didn't do as many as you. And I'm always like, nah, this isn't shaming. Changing behavior is super hard,
yeah.
and all of that stuff that comes with it. So I always take that as a time to kind of go, no, it's okay. It might be that we need to change things, and that's okay. But you need to tell me. You do not need to be sorry about it.
And you mentioned the video. And I'm also a big proponent of videoing any advice I'm going to give, or
Yeah.
and for my explanations, they can record, but I often will get them to use voice record on their phone, so they can
Oh,
hear the
cool. Yeah.
sound, and I draw as well, like you. But the final principle is about increasing commitment and consistency, and I know that if we can give them more personalized advice, especially in video, they're more likely to do it compared to if we give them the generic sheet or even just written out stick men. The more visual it is,
Yeah.
as you said about visual people earlier, um,
Mm.
the more likely to do it from that. And it's also more personal as well. If it's on their
Yeah.
phone and it's their exercise, and it might be them doing it. Sometimes I do it if they find it difficult, and
Yeah.
that's fine. I'm happy to be videoed. But I think that's one way I've found, at least, that helps increase the consistent commitment to the plan. What else have you found helps
Yeah.
increase commitment and consistency?
Oh, I absolutely, so my course is all about this really, I absolutely love it. I could talk about all this. So I'll keep it fairly short. One study I always love, there's always one study that helps and bored, people probably who have heard me speak before is bored of it, but commitment is such an interesting thing. And the study that was done in the 60s was about estimating the length of a line. So there was this
Oh,
study where they
yes,
asked these,
yeah.
I don't know if you remember this, they asked them to estimate a line, and the first group were told to publicly commit to the group what they said the estimation was. The second group were to write it down on a magic pad that only the researchers saw. And once they wrote it down, they lifted the page and it disappeared immediately. So they saw
Mm.
it, the researchers saw it, but nobody else saw it. And it only lasted for that second or two. And then the last group were allowed to keep it in their heads, not say it, not write it down, but the researchers knew. So they told them, but that was it. And then what they did was they then said they were all wrong. So they all told them individually that their estimations were incorrect and would they
Mhm.
like to change, right? And the group that were significantly less likely to change, despite being wrong, being told they're wrong, they were less likely, was the ones who told everybody that they
Mm.
committed publicly. So public, I think he mentions it, Cialdini. I think this is a
Yes.
public commitments are lasting commitments.
Yeah.
So that idea, now that could be positive or negative, which I'll come back to. But interestingly, the group that wrote it down for a second, they also were quite significantly not likely to change their mind either. And the ones who were significantly likely to change their mind were the ones obviously in their head, because you can be flaky when you're, because that's what it's seen, isn't it? If you go back on what you said, you're a flake, or you're not really confident. And that's why people dig their heels in politics or in therapy and say, all right, well, this said this and this said that. You see it everywhere, don't you? But when it comes to commitment, I'm always accountability and telling people and having it written down and getting them to show pictures of it. Going home and telling whoever if that they're going to do it. Tell people. Sometimes people are motivated by negative. So like the person that they know at the office is a real pain in the ass. Tell them that they're going to do the marathon or they're going to do the exercise, and then on that Tuesday night when they're can't be bothered, they see Dave or Sharon in their face, telling them that they were never going to do it in the first place. So I'm very much interested in emotional intelligence and how people's minds change, especially around like the work of Steve Peters, the Jim Paradox, or Daniel Kahneman's Thinking Fast and Slow and stuff like that. Those kind of things of how we manage our emotional states when it comes to exercise commitment as well. So I try and give patients ideas that, look, you're going to get hijacked by your emotions and then you're not going to want to do this. So let's put in a plan on that night. You're going to just do this. Don't worry about doing the whole program. Don't worry about doing it. If anything, just make sure you do these things, or even just a movement thing or a walk, or listen, anything that's positive. Don't worry. Don't feel bad, because a lot of the times when people, I'm sure you've heard it, like, I'm an all or nothing person, and all they have to do is just stop at that one time, and then they're off, and they're like, oh, I don't do it anymore. So I'm very much always trying to predict that their behavior, and the reason how I can potentially predict it is back to what I said at the beginning, which is exploring them and seeing them as a personality and what they like doing, and writing those things down and asking them questions around how they've done things in the past, because then we use that then in the exercise commitment side.
The sharing with the I've had the same thing. The more people they can tell, the more likely it's going to get done, essentially. The ideal is that they go and plaster it all over their social media, and they tell as many people. Now, we can't expect our patients to do most of that, but even if in the, what's it called, Atomic Habits, he talks about a commitment buddy or commitment thing, where just someone or something you can tell that you're going to do it, you're more likely to do it. This is one of the benefits of having a friend or family member with them, because you're not just telling, they're not just committing to you, they're committing to that person with them as well. But ideally, the more people they can tell and track their progress, the better, essentially.
Absolutely, yeah. And I think it was 76% more likely if you tell somebody in some of the papers that were written on that, in comparison to not having accountability. It's why, like, again, people who do this really well are personal trainers. They have some really good stuff. Like I got a free prize. I told a story before, but I got a 3-month free personal trainer, and it was all online coaching. So she just sent me I had to fill out this paperwork, about 5 pages long. It was a big, long thing. And I had to sign it at the end. And that included my goals and why. And then the app was basically sends through the program, and I just go on the app, go and do my training, and then put in everything I did and make little comments. And then I used to write some daft stuff on there just to make her laugh a little bit, just because it was funny. Like, I saw my soul when I did that last rep or something like that, which was kind of true. But she'd laugh, but she didn't have to say anything apart from like a fire emoji or just like simple things back. And I was like, oh, right, great. But I remember one night, it was my wife's 40th birthday the night before. So we had a nice time, and I was hungover like a monkey the next day. And I was on my son's floor. Like we share the same kind of kids, twins and all that. So we were, you know what it's like when you're lying on the ground, and I was just asleep. It was a Sunday night, and it was 9:30 or something like that. And I just kind of went, oh, I'm supposed to be in the gym. I haven't done my session. And it was stood up, went down the stairs, in gear on, out the door, came into the clinic, started doing the workout. And there is just absolutely the only thing that wasn't letting me down was going, there's no way I'm missing a session in these 3 months. And all she then just wrote back was just, so it's so powerful. Like, I think we need to do it more, contracting people, working on that side of things. I think, I think in coaching, if anyone does any coaching training, contracting is so important. And I think physios are now trying to, certainly they're in the States, they're doing it. And there's some in the UK, is this hybrid idea of you don't always have to see people, just even phone call,
Yeah.
coaching and stuff like that. I do it quite a lot as well. It works really well. And I think people just need that. And people are aware of it. They know, well, especially successful people, they'll often say, look, I want to come back to you in 6 weeks. And I'm like, you don't really need to. And they'll go, no, I need to come back to you in 6 weeks just to say I've done it.
Yeah. Yeah.
So it's interesting.
The having the response, knowing you have to tell them at some point
Yeah.
how you've got on. Which is
Yeah.
great for extrinsic motivation in the short term. Obviously, we ideally in the long term want them to have it intrinsically.
Yeah.
But I think you're right. And at least definitely in the short term, having someone or something to tell how you're going to get on will increase your chances, as we said earlier. There's also an important point you made about you actually ask about the barriers in advance, like what will stop you or what will get in the way, which I think sometimes people are scared to do because they feel that, oh, they're going to start throwing up excuses or that will kind of knock us off track. But you're addressing an elephant in the room, which is important. And if anything, it's just going to come up down the road anyway. So I agree with you. It's better to deal with it now when you've made the plan rather than waste however long, 4 weeks, 6, and then they come back and say, oh, I couldn't do this because da, 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 which could have been said at the time.
Yeah, like that's why that early first appointment sets sets the standards and the pillars or foundations, whatever words you want to use, for them to be able to come back and say, yes, this is working, this is not working. So I'm always like, even especially young kids as well, like you need to tell me, we're trying to get you on that field again. So we need to talk, we need to be one. And the information, so from the very beginning, because that's what you know what it's like. You know, when you get it, you just get, sometimes you pick up a patient off another therapist. That's a common one I'll see in the NHS, where someone will bring a problem patient to me. They've seen a patient and I'll be like, what happened? And they went, well, I got it handed over from a previous therapist. And I went, that's usually the problem. They don't do that. There's a change. And all they do is they carry on what was being done. It doesn't work. And now they're like, I'm four appointments in. They're 10 appointments in. And they're like, I haven't really developed that connection. And now I don't know what's going on. So they come really like, oh, I don't know where I am. Don't even know. They're looking through their notes and they're like, oh, I'm not sure. So then we say, right, well, let's do a joint session. And the joint session is, I get them in and I say, right, from the start, you start again. You build a relationship. You stay where they are. You have to rebuild that. You can't just hope, you know what I mean? I've seen that too many times, you know?
Yeah. And sometimes, I should say sometimes, and I'm sure you've seen it at times or other people have, when it just needs a different person for them to see, even if you're giving the same message, but just someone slightly different, for whatever reason that they're different, it's a different time, a different place, whatever, that it just clicks that time. You may not have suggested anything different, you may not have done anything different, but it's just how it is at the time. It just clicks. I'm just starting again.
Absolutely. Yeah. No, they definitely agree.
I realise we're scratching the surface with this. And was there anything in your notes that you wanted to say about all this influence and persuasion stuff that we haven't discussed?
No, I think we've done a good job. I think you know, I just think if you're listening and you're a therapist, or even not, depends on what kind of area you're in, because this crosses over all areas. Like I said, I read marketing and books about like you know, don't split the difference, which was like he's an hostage negotiator, you know, all that kind of stuff. I interviewed Mike James and he loves all that kind of stuff, and he gave me some great books to look at. And so it's just making sure that you definitely read around it. You know, I can't remember who was saying this to as well, but like, you know, the physical side of what we do, the kind of pathologies, they're changing and there's research coming out on it, and it doesn't massively change though. You know what I mean? It's not like, you know, exercises haven't changed in, you know, thousands of years. You know, they're still doing the same stuff. People try and, you know, it makes me laugh, you know, on social media. People are like, oh yeah, here's this new program. And I go, it just sounds like the same program that everyone else has done. It's just slightly different, and things are changing it slightly in muscle physiology, but it's like super slow. Whereas the biggest industry we've got at the moment is communication. It's unbelievable. It's taken over the world. Like social media's communication platforms, and it's constantly changing. Like every 6 months it's different. Like there's a new way of sending a video. It's a new way of, and you're thinking, no, there can't be anything different now. And now it's like, no, it's going to be like this, and it's going to be delivered like this. And you can see the spec of the videos and everything is. So it just, I think my point really is just, this is an area that just needs to be explored more as a therapist. And I think people are scared of it. I don't know why, because I think if you get interested in it, it will absolutely change every aspect of your life, not just as a therapist, you know?
Yeah, agree. And probably have, I'm going to bias saying this, but probably have a bigger impact than other things you've learned to date. Um,
Yeah.
yeah. What I ask everyone this, and you knew I was not asked this. What is the
Yeah.
hardest conversation you've had clinically?
Yeah, I know you're going to ask me this. And then I was like, and then when you say it like that, I'm like, oh, I probably could have come up with a better one. Hardest clinical conversation. You know, well, I'll tell you a very quick story, but then there's what I'd say is I've learned to love hard conversations.
Mm.
So in the past, you know what I mean? Like I remember a demographic, if you'd asked me 10 years ago, I'd be in the NHS and I'd read a referral and you know, it's a bit harsh, but it would be the soul sucking patient. You know, you'd just be like, oh no, this isn't going to go well. And I'd nearly prepare my mind, which was really bad. I do the opposite now, but it would nearly be like, oh God, this is going to just, I'm never going to get this hour back or whatever, you know?
Yeah.
And there was something that flipped in my mind, and I don't know what it was, but something meant you need to start loving these people. You need to, not in a kind of weird way, but like you need to start liking solving this problem
Yeah.
because there's a big majority of your caseload's going to be complicated. And I try and get therapists to do that. I say, like, think of your worst patient, like, the ones that just come in and it doesn't go well. It could be a gender, it could be an age, it could be a job, it could be a personality. Think of them and then think of your favorite one. And then I try and get them to think of, well, how many sit towards the least favorite and how many sit towards your favorite. And it's generally going to be a mix. So I'm like, so there's a big majority of people that you're not going to like, that you're going to clash, that you're going to struggle with. You need to be able to find a way of making those difficult, hard conversations better and more enjoyable
Yeah.
and a problem solving side of things. But where I made a big mistake was, and I've learned from it big time, was I saw a patient and it was a lady who had seen absolutely everybody. And it was I primed her on the phone. So she spoke. I tend to speak to my private patients on the phone. So I'd spoken to her and I could kind of clearly see that this was a persistent pain problem. She had been imaged within an inch of her life. And she was on the search for that one thing that was causing her pain. That classic one. They've just not found it yet.
Yes. Yeah.
So she came in and we went through the story an hour and a half. And she went through the story and I was at the time when, knee deep in Mosley and all that kind of crack. And I thought I had my pain science stuff down and I thought I was listening and I thought I was getting everything what she said. And I clearly see that what she was doing was she was one of those kind of like what I would call stiff backs. Everything was back, deadlift, everything was like you were lifting a pen and it was something biomechanically wrong with her. And what I did was, the mistake I made was she wanted me to absolutely, like, I didn't realize this till afterwards. So I'm going through all this conversation and understanding and talking about this and that. And she's nodding away. And I think I've got her. And I think, oh yeah, I'm the one who's broken through here. She's seen all these other people. They've all tried to do the mechanical stuff. I've nailed this. And it got to the end anyway. And she went, all you've not done very much. And I said, she just kind of suddenly flipped and went, you haven't done very much. And I went, sorry. And she went, well, you've asked me to move my back a little bit and do a few bits, but I'm not sure, you haven't really assessed me properly. I said, no, we've done these bits. And I said, what you do is you can come, you've got to get your back and then I'll go through this. And she went, oh, but we've had 90 minutes and you've not really done anything. And I went like, oh shit. And it was one of the things, like, I haven't listened to her at all. I haven't really listened to her. I thought I had. And it was a really hard conversation. So I had to say to her, I said, look, tell you what, she'd pay. She would, no, I'll pay you. And I said, tell you what, if on Monday, if you think you don't want to, I'll give you a refund. And she texted me on Monday and said, I'd like a refund. I said, no problem. So I sent her back the money and that was that. And then on reflection, and I don't know if it's a really hard conversation. It was a hard learning point, but the thing is that she came to see me to go through a really heavily biomechanical assessment. She wanted me to get her on all my testing equipment, but it was totally irrelevant for her. She was, all the stuff she told me that was not going to help her problem. And in my head, I was going to fix her problem. But she wanted me to give her nearly that proof of you've done some tests, you've found something, and then you're going to fix it with an exercise. And I completely missed it. But it was a really good learning environment because since then I picked up on that earlier where I'm going, no, don't go down that route, Andrew. You think you know the answer here, but it's not that. They want this first, and then you can maybe deliver it. So it was a really hard lesson because it was really embarrassing because I was just mortified. I thought I'd done a great job, and I was really afraid she'd leave a really bad review and all that. And it was really it was a hard one. But I suppose that was a hard conversation because I was hijacked by my own ego.
Okay. But and thank you for sharing, first of all, because it's important. It's often the tougher ones that the ones we remember. Was there anything you, apart from, as you say, maybe using those machines? And this is some of the points I often tell people. We know that the objective tests we do don't add much compared to the subjective generally. But the patient's feeling that they've gone through that and that you've assessed them helps with the buy-in for the later parts. Was there anything you'd have done differently, aside from those things, maybe, or maybe not, that you'd have done different if she'd have come back?
So my plan that it was interesting because I was planning to go through it. She just didn't let me get there. You know what I mean? Like I just had done, but I reversed. Instead of going, right, I've done all these tests and actually, look, brilliant. And here's your results. And I think actually what you've got is this, you just don't move your back a lot. And then I could have delivered that information. I preempted because what she had told me, I had a look at a few things and I went, even the way her pain behaved and everything, I was just like, this doesn't need testing. Like you just said, but she needed that. And I've had someone recently email me going, your thorough assessment led me to this. So, for some people that is needed. They need that thorough, and I get that. It was just, it's always you just don't know who you've got in front of you. You don't know how they're ticked. We think we might know, this or that about people, and it's why I then came up with this idea of exploring people first and making sure I contract them to what are we doing in the session today. You know what I mean? Like what are you expecting from this session? And I didn't do that with her. I just got carried away with thinking I could have easily said that was the right thing to do for her. I would have hoped it was, but I didn't do it in the right way. And then I kind of realized I just went, look, I'll give you the money back. Maybe there was definitely part of me also that made me went, I don't think there was definitely a personality thing that I was like, I feel uncomfortable with you here. And I think this could go wrong. There was something uncomfortable. My gut feeling went, so I had no hesitation to say, I'll give you your money back. I don't need, if in the NHS, it would have been different, but because I was like going, I need to cut away from this. And I remember a psychiatrist actually was saying, identifying certain types of personalities. He put up something slides and he went, these type of people here, you've just got, and he put up a number of characteristics. I won't go through them now, but and it was like going, these people will not get better from your type of treatment. You've got to be very clear. And I noticed over the last 10 years that there's a certain trend, again, in a certain type of psychological profile that they yo-yo around the place. They've seen lots of people and interesting within a subjective, they try and bounce around. It's really interesting. I've actually seen it with problem patients with a colleague of mine. So the two of us were like, oh my God, this woman was moving around and back and forward. And I kept having to go, so what are we doing here? I had to kept bringing her back to the message because she would go off and around and come back again. And we'd still be like, no, we need to decide on what we're doing here. You've not said anything. And it straight away, his thing was, these people you need to identify them and then be very clear about the rules. Otherwise you will get lost.
Yes.
So that was quite interesting to bear in mind as well. It's just sometimes some people you just may not be your type, and you might need to just say, look, you know what, someone else needs to see this person,
Yeah.
and yeah, move on.
Yeah. We can't get on with everyone, can we?
No,
There's just some people
no,
you're not going to click with, and that's okay.
no.
For whatever reason it is. I like to end these on a positive. So the final question for you was, when is a time you thought you couldn't influence or persuade someone, but were able to?
Yeah, God, I was trying to think of this answer as well. Sorry, I could disappoint you here
It's all right.
potentially.
It's fine.
I kind of when I thought there's been loads. There's been you know what I suppose, which is maybe hopefully a more authentic answer from me, is that I've definitely gone in and judged people. But like, I'm very honest with regards to, I judge people just like everybody else. You know, as harshly. If I'm going to put myself out there, I'm like going, there'll be some things you'll just be like, nah. In the part of me is definitely that's happening in a consultation at times, without doubt. There's judgment, and it's negative judgment. And it depends on, again, on what time of day and how tired I am and all that kind of stuff. But there'll be definitely that happening. And what I've done, hopefully, and tried to do as well is I've got that wrong so many times, like unbelievably bad hit rate on the fact that this person's going to be this and this person's going to be, and I've now started turning it into a game where I used to write down all these things that I used to write it down on a piece of paper, and then do the consultation.
Yeah.
And at the start, because people are anxious, often they can be rude or angry.
Yep. Yep.
And that's the tricky bit, you know what I mean? Because they can really annoy you, really piss you off and really trigger your emotions and be like, this and that, and really, I tell you what, I had a patient not long ago, and she is the exact same day of birth as me, like same date of birth. And I'm always I'm a bit quirky like that. I'm like, so she's coming down, same age, walking down. I was kind of hoping, hope you're sound, hope you're like my twin that I've never met. And she came in, and I said, first thing I just decided to go with the opening line was, I said, me and you have exactly the same birthday. And she replied with, well, you better fucking sort me out then, or something like that. It was really like aggro, not nice.
Yeah.
Like with the whole kind of like sat down huff. And I was like, wow, that did not land how I thought it was going to land. And it was interesting. So I was straight away going, this is really hard. And my instant judgment went, you're not a very nice person. But because I've tried to train myself recently, it's like going, you know what? Let's give this a chance. And by the 15 minutes in, I'm like going, I now know why you're like that, because she had been treated pretty badly, and the situation she was in was really bad.
Yeah.
So the empathy side of things helped me kind of change that. And I think, to go back to your question, which is like, when I thought I could influence people, I have got people to come round where they've kind of gone, I've even at times like I've gone, there's definitely a head-to-head. There's been like quite a, like both of us, I'm like going, excuse me now, sorry, can we just be very clear about what you've just said there? Like there's definitely confrontation to it, because they've been maybe slightly stepping over the mark. And maybe I've got them wrong, or they've said something, but I will instantly apologize. I tell you what, like, I'm really sorry. I didn't mean to do that. I'm happy with that kind of apology in the middle of a session. So let's start again. And then we get through it. And at the end, I've had this several times where two people are like, I've shaken hands and going, well, we got there in the end, and it was good. And they're like, yeah, that was positive. And it's just because I'm really sorry. It's just because I've had this for such a long time, and et cetera, et cetera. And they turn out to be really nice people. So I think it's happened several times, but it's just, I suppose if you're listening, just hang on to it. Patients are usually really anxious, and that drives weird emotions. Just always hang on as long as you can. And as long as people aren't super rude to you, you can often change it.
Yeah, that's a very important
That would
point.
be my...
I know we're not talking about anger management today, but I think, especially if you're seeing them for the first time, like if they're coming in angry and hot about something, it's probably nothing to do with you or what you've done. Because they can't be angry at you for something because you've not done anything. I've just like you, I remember seeing someone who's, again, very angry, very frustrated, from treatment she'd had in the past and her experiences, and then came back the next time and was very apologetic to how she was. And again, it was just like you, sat there and after 10, 15 minutes knew why she was angry, knew why she was so frustrated. And I say this to people, as long as you feel safe and not threatened,
Yeah.
actually
Yeah.
being able to sit there, and people say this all the time, let them vent, let them get out, then it, in the long term, will have the positive, because you're being that person for them that they may not have had so far.
Yeah. And it doesn't take much. I think empathy is a skill. I think we can get better at it. I think,
Yeah.
we need to practice it. It takes emotional intelligence, doesn't come out of thin air. You have to work on your own thing, and sitting in there with those kind of feelings. But it is definitely a reward, because people often will, you're dead right. It's that kind of idea of keep reminding yourself. And sometimes patients come in and I'm like going, you're absolutely right. Like they'll finish their event and I'm like going, no wonder you're frustrated and angry
Yeah.
about it, because but and then I'll usually say, look, you've been waiting 9 months. I get it. What are we going to do? Like, I'm here now to get you where you need to be. So
Yeah.
it'd be great now if we could move towards that.
Yeah.
Nearly like that's in the past. We've dealt with that. They don't need to feel any shame about being angry, because they often do a little bit when they've done it. And then we can kind of go again, we're moving on to this next stage. I'm going to get you to where you need to be, and we're going to work together. That unity principle again, like he was saying. So I
Yeah,
think that's
absolutely.
quite key.
So just so people are aware, you are on Twitter, Instagram, LinkedIn.
Yeah.
Any other social media I've missed?
Facebook, but I don't, yeah,
Okay.
whatever. But Pro Care Sports on Instagram is where I like to hang out there. McCauley Andrew on Twitter, and LinkedIn is Andrew McCauley.
And they're all going to be in the
So yeah.
description of this. You've got the Therapeutic Conversations Unraveled podcast, or teacup, for a better, nice analogy. People
Yeah.
can, I'll put the links and people can go and download now.
Thank you.
And the Unravelling S&C course.
Yeah, that's right.
Although,
So
as you,
that's a kind of a course as well. It's interesting. There's a lot of coaching, a lot of communication.
yeah,
Obviously, there's a lot of physical side of things, but it's effect. We have a difficult job. We have to try to get a lot of people who don't want to exercise and hopefully use exercise. So it's very much about how do you work out the dosage for the patient in front of you. So there's a big communication element. There's a big trust, the research around it. And then, so if you do have a patient, how you improve the quality rather than quantity of things. Yeah. So we go through the adherence research and stuff like that. So it's quite key about, like, if you've got a patient who doesn't like exercise, how do you dose them versus somebody who likes to go to the gym 5 times a week? So we work that out and apply the rehab principles to that. So it's a bit of crack as well. I like a bit of fun on it.
and people want you to come to them to do the course, they can contact you on one of those platforms.
Yep, absolutely. You can DM me, and usually I have a link tree in my Instagram, which is I've got courses on there, or I do a lot of private ones as well, where people just come and say, "Would you want to come and do it like in the hospital and 15, 20 physios?" And we do it that way. So if they want to maybe set a course up and stuff like that, yeah, just get in touch.
And anything else you want to plug that I've missed?
No, that's great.
No,
I really
no.
enjoyed talking to you.
Likewise, mate.
I really like this topic.
Me too. I'm glad. And I hope people have this value in it, because I think this will be applicable across whatever speciality you're in, whatever condition you're seeing, whatever career path you're on, regardless of who you're treating. These principles, as we've discussed today, will be useful. Anything else you want to say, mate, before we go?
No, it's just that some of the best people in the world who, like experienced people who've been on your podcast, have been on mine,
Yeah.
all say the same thing. So and across all specialties, like you said, whether it's pediatrics, elderly care, frailty, sports, you name it, the top people in the world, the researchers, and it's clear that this is important, and it's probably more important than you think.
Absolutely.